talk about it. It's a very quick case. We had a fantastic session yesterday at the Venus Summit where we talked about a lot of emerging technologies and different ways to evaluate and how to improve patients and things like this. So I think this might be relevant because it will go back to our focus on indications being the most prominent thing that we need to focus on for our patients. I have no relevant disclosures. All right. 83-year-old male, history of aortic valve disease, status post-TAVR, hypothyroidism, pretty significant Alzheimer's disease, prostate cancer, status post-brachytherapy and seed implant, has some end-of-the-day right leg swelling that's been intermittent over the past year, control with some compression and only minimally symptomatic. And here's the pictures that you see. He's got some venous stasis changes and some swelling that you can see along the leg on the right side, but really nothing. In addition to that, you don't see significant hyperpigmentation and you don't see any kind of venous ulceration. So this is a patient who is C3. I don't know. Let me just pause right here. Do we get studies for this patient?
Vishal? Yeah, I think we should.
Yeah, I think we always get them. They came to you for leg swelling. A lot of the times, I guess they're asking you for kind of prognosis and how do I manage this. So, the patient got a duplex ultrasound, and here you go. I guess a lot of words, so we'll focus on just the bottom conclusions. On the right side, negative for a DVT and SVT. Incompetent small saphenous vein with a reflux time of greater than 2 seconds, which you can, sorry, let me go backwards. With a reflux time of greater than 2 seconds, that has a maximum vein diameter up to 6.5 millimeters. And then also evaluation of the iliac vein demonstrates a severe proximal external iliac vein stenosis with a vein diameter of 3 millimeters. Further evaluation may be warranted. Let me just pause here. Can I just ask, at this point, who wants to offer an intervention? What intervention would you want to offer?
When the patient is symptomatic and like FEMA is like very soon gonna lead to DVT, probably like some balloon angioplasty or with a stenting. I think it's all of the options.
So I think it's reasonable, right? Interesting. So you're addressing the leg swelling for this patient because they came in with leg swelling, and I guess and the thing that you're addressing is not necessarily the small saphenous vein reflux. You're talking about the external iliac vein stenosis. Now, does the patient's prostate cancer, brachytherapy, potential for going back for more prostate surgery, does that come into play at all in your mind?
Eventually, but we treat the symptoms first. If it is significant and this patient at risk for other problems like disease, and making things worse with coagulation, I would say we can do like reset there. How do we go with
That's a great point, right? So anyone with a cancer history, is this like an inherent venous issue, or is there some sort of external compression that's on the outside? We don't know. There's a lot of information that we don't know.
Or the brachytherapy itself, could be causing fibrosis of the veins.
Not to belabor the point, but this is kind of after I inherited him. The procedure that we went on to get for this patient, for some reason, was a right SSV RFA.
Wow.
I think oftentimes we think about it being simple. We see a lot of kind of aggressive venous therapies that are happening now, and potentially the discussion may have been that this may help with your leg fatigue. This may help with some of the symptoms that you have. So the patient ended up getting a right SSV RFA. Of note, there were no varicosities in the SSV distribution. Even if they were, we described the patient who has pretty significant Alzheimer's, 83 years old, cancer, and had some leg swelling, but really was controlled decently with compression. And then this concern about ongoing cancer therapy in this kind of patient. And then this is a question I always have. If a patient does have chronic leg swelling and then you ablate their saphenous vein in the setting of an outflow obstruction, is that a higher setup for a DVT?
I think so.
Presumably, right? I mean, like oftentimes after the procedure, that patient needs to be wrapped and walk around like crazy.
Especially post-cancer patient. Now that they are talking about phlebolymphodema rather than just pure lymphedema or lymphedema. So this patient, would you worry about, like, is there an underlying lymphatic component versus purely venous? that's something you look into?
Absolutely. I mean, this patient had brachytherapy as well as seed implantation in the entire segment. I mean, and once again, where are we talking about in terms of where the lesion is? External iliac vein. You talk about Mather in the pathology and things like this. You can see it by all means, but the more common typical location is going to be your left, the contralateral left common iliac vein. So for us to see something in the right distal external iliac vein was a little odd. The patient initially had a duplex ultrasound 1 day after the procedure, which showed that the SSV was properly ablated and that the deep veins were open. Post-op day 4, significantly worsened right leg swelling and discomfort. The duplex essentially shows everything from the external iliac vein down, common iliac vein down, with acute thrombus going all the way down that leg. And his leg had almost quadrupled in size, and he was extremely uncomfortable, which is where we ended up getting involved. We had a fantastic session yesterday about single session venous thrombectomy and things like this. So at this point, I don't know, panelists, would we want to do something here? Or do we just...
It's actually very interesting. By doing just right SSV, he has extensive clot all the way up to the, I guess, common femoral. Or, I mean, it's hard to explain. I mean, the patient has underlying cancer, so I don't know if there's a component to that part. But technically, when you do a right SSV, you could have a DVT of the poplite extension if it meets the again. SSV has different anatomy. It's not as consistent as the GSV. So if it meets the popliteal, you might see a little bit of popliteal DVT junction extension. But having such a significant DVT all the way up is pretty impressive. I mean, I'm sure he needs. He needs an invasive or an acute treatment rather than just pure oral anticoagulation, especially, like you said, worsening quadruple size. Yeah, he needs more aggressive invasive therapy. That would be my next approach.
Yeah, and then to Sandeep's point, when you ended up going down to the CAT scan, you actually don't see significant masses there, but you do see significant amount of lymph nodes around that external iliac vein, around the area where they have implanted seeds. So the concern here was that the patient had associated acute thrombus, but also potentially some chronic elements as well around that external iliac vein related to his cancer. So we decided to do a single session thrombectomy for this patient. Before we went in, we had a full discussion about everything. This is a patient and family that at this point were pretty pissed. There's clear, so the goal was just get me back to where I was before, clear the clot. And we had a long discussion, to your point, about whether or not we should treat that external iliac vein stent, especially in this kind of cancer setting. Potentially difficult. The patient may require additional cancer therapy for, we talked with the urologist with the enlarging lymph nodes. They were potentially thinking that they would have to do more interventions beyond this point. Then do we put in an external iliac vein stent across that entire segment? Will it make our therapy any more difficult or challenging? Do they have to keep them on anticoagulation even longer? So our ultimate goal was just to clear the clot in the popliteal femoral and iliac veins and just leave everything alone, because that's where he lived previously. We put him prone, popliteal access, and from this point on is fairly straightforward. We talked about many different single session thrombectomy options. It's a great time for single session thrombectomy now, and our options have expanded over the past 5 years. The one that we chose to use here was an angiojet Zolante, because we did want to put some TPA across that chronic segment so we can clear some clot. And after we did the power pulse and thrombectomy, this is kind of what we got. We were able to completely clear the fempop region. And then this is the culprit lesion around the area in the external iliac vein. We kept him at exactly where we talked about, and he had returned to baseline, so we left it here. IVUS actually demonstrated it was, narrow, but one of the things that you don't see is significant collateralization around this area, and we felt that this is where the patient had lived for years, so this is where we actually left them. So it's a very straightforward case, and superficial vein ablations, you're seeing increasing in popularity across, and it can seem very harmless, but can have significantly major consequences for these patients. It should be performed with caution, especially in setting of known outflow compromise. A patient has unilateral asymmetric leg swelling. That's a person that I significantly pause and think about doing any kind of superficial venous ablation. And then the good thing is, at least if that does happen, our percutaneous thrombectomy options are pretty good these days.
Sorry, Dan, I think I missed it, but you didn't stent that externally yet.
We did not. And part of it came from the whole discussion even before. And we had a long discussion with their urologist about the state of their cancer, which they were potentially thinking about going and intervening and taking biopsies of the lymph nodes that were enlarging around the area. So, for me, in my mind, this was a setup: outflow obstruction, recent intervention with a SSVRFA, and active cancer. It's like a trifecta to kind of give you this kind of DVT.
Very nice. That's good.
Let's say different patient, like pain, like swelling, give duplex GSV, SSV reflux, but they also look at the coming from iliac stenosis. Which do you treat first?
It's always a good question. I think it's setting expectations for the patient, right? So in terms of significant leg swelling on one side or the other, the GSV ablations and superficial vein ablations may help a little bit, but not a lot. I think majority of the leg swelling issues comes from a central vein stenosis from a Mather's or something like this. And while you may have some symptomatic relief in terms of your legs may feel a little bit less tired, you may get a little less itchy legs or something like this, I don't think it tremendously helps with leg swelling per se if you do a GSV. And if the expectation by the patient is that their swelling is going to go away when you get to their GSV, it doesn't really make sense. And if you think physiologically, when you're closing down the superficial veins, you're redirecting all the circulation to the deep veins, which already has an underlying problem as its outflow. You can potentially make the problem worse.
Yeah, I mean, I think that's a great point. I mean, especially like you said, we're doing superficial venous ablation. You always have to tell the patient that the swelling might not go down because you have even deep venous insufficiency, which is pretty much underdiagnosed, in addition to being stenosis as the problem of edema. So even though there might be CAP classification C3, the effect on swelling is not as significant or not as obvious. So the medical management, including stockings, elevation, and all the stuff, carry along stuff, especially with the swelling part. Yeah, great.
You're out in these patients that are in the office, you are like identify results. Our sometimes go off and identify the symptoms. You love either way. So when you get some for CTV, MRV,
I do. And we talked about this yesterday's session. Some labs are starting to look at iliac veins with duplex ultrasounds, and they're getting a little bit better. Our lab does not. So I routinely get cross-sectional imaging for patients who have significant leg swelling. Thank you so much to the moderators because you guys were much nicer than the prior moderators. And you didn't have
Dan, the only thing, Dan, I have a question. I know I know what happened here. I mean, again, SSV ablation here doesn't make sense. I think just reiterating what Dan's point was, I know how many of you guys admitted the venous summit part. Venous ablations should not be done for edemas.
Correct.
Superficial vein ablations are not done for edemas. I think any of you guys who have done a lot of venous ablations know that that's not the case. Usually, significant edema comes either from lymphatic system or from deep vein insufficiency. Usually, vein ablations are done for pain and varicose veins, or you have frequent thrombophlebitis or something like that. So,
or ulcers.
Ulcers.
Yeah.
But I think stenting, I'm just surprised. Why didn't you stent? You didn't think that if you didn't leave her on a long-term anticoagulation, she would form a DVT again?
Yeah, no, I could have gone either way. And a lot of it was we had a team meeting between the family as well as the urologist. And when they were talking about how long would you leave this patient on anticoagulation, we treated him like a DVT. He was going to stay on 3 months full anticoagulation and nothing beyond that. The concern was with instrumentation of the lymph nodes around the stent graft. I don't know. I actually have no idea. Is that going to be an issue for the urologist? So the goal was just to put him back where he was.
But when you IVAS did, you thought it was compression or you thought it was fibrosis because of the brachytherapy?
Yeah, probably with some fibrosis because of the brachytherapy, and you did see that around it.
Because that's what it looks like, right? It looks like there was already some thrombotic component because of fibrosis and brachytherapy. That's why I'm saying, like, if it's fibrosis, if you leave it, I think she's going to form more anticoagulation with all the cancer therapy going on, putting her on long-term anticoagulation. I think that's the reason that's the culprit, right?
That's a good point. I'll call him back. We'll bring him back to the office.
I'm just asking. I don't know. I don't know if it's right or wrong. I'm just asking.
Yeah, I don't know either way, but we definitely could have treated it.